Ebstein Anomaly definition. It is a rare congenital malformation characterized by apical or distal displacement of septal and often the posterior leaflet of tricuspid valve into RV cavity, along with other morphological abnormalities of valve leaflets and their attachments. Dysplasia of leaflets, dilatation of tricuspid annulus, dilatation of right ventricle. Now the anatomy. Three leaflets of tricuspid valve, anterior, septal and posterior leaflet. Leaflets of tricuspid valve attaches more distally than mitral valve, that is more than 8 mm per meter square body surface area from mitral valve insertions. RV is divided into two parts, proximal atrialized portion and distal small functional portion. Now the associations of Ebstein anomaly. Very common association is tricuspid regurgitation due to redundant long anterior leaflet of tricuspid valve. WPW syndrome type B. 1/3 case are associated with ASD or PFO. Less common associations are PDA, VSD, pulmonary stenosis, pulmonary atresia. Commonly found in patients with congenitally corrected TGA. Now, natural history of Ebstein anomaly. Natural history is variable, depends on age of presentation, functional class of presentation, presence of associated defects. 40% patients present in neonatal period having severe TR and pulmonary atresia or pulmonary stenosis have poor prognosis. Nearly 60% adult patients with NYJ 1 or 2 survival beyond 50 years of age. Adult patients usually present with cyanosis due to right to left shunt through ASD or PFO, dyspnea and fatigue due to reduced cardiac output and reduced preload due to small RV, palpitation secondary to atrial arrhythmia. Now, what is the cause of death in Ebstein anomaly? 20% unoperated patients may die from heart failure. 5% patients may die suddenly from atrial or ventricular arrhythmia. Now, what is the clinical feature of Ebstein anomaly? Cyanosis, palpitation and faintness, dyspnea and fatigue, heart failure. What is the exam findings in Ebstein anomaly? JBP may normal, raised V wave due to TR. Heart sounds. First heart sound widely split due to delayed closure of tricuspid valve. Second heart sound often split due to RBBB. Third heart sound over right ventricle. Fourth heart sound not uncommon. Cadence of triple rhythm, diastolic noise. Now, what is cadence of triple rhythm? Most characteristic feature of Ebstein anomaly, heart to right of sternum, closely resembles pericardial friction over distended right atrium. When this sound is loud, it is due to an opening snap from large anterior cusp. Now, murmur, pansystolic murmur of tricuspid regurgitation. Association are ejection systolic murmur of pulmonary stenosis, continuous murmur of PDA, pansystolic murmur of VSD if present. Now, what is the investigations? The investigations are ECG. ECG shows large Himalayan P wave in lead 2 V1 V2. PR interval prolonged due to delayed conduction associated with large right atrium. WPW syndrome type B, more than one accessory pathway involved, concealed pathway. RBBB, partial or complete. Voltage of QRS low and bizarre. atrial fibrillation, atrial flutter may present. Chest X-ray findings: normal in mild case, extreme cardiomegaly in severe case, globular form resemble pericardial effusion, oligemic lung field, some tissues shape of heart box shape heart. Now, what is the findings in echocardiography? Apical four-chamber view shows hugely dilated right atrium, downward displacement of septal leaflet more than 8 mm per meter square body surface area, large redundant anterior leaflet, tricuspid valve annulus dilated, color Doppler shows tricuspid regurgitation. The associated defects are PFO or ASD, VSD, pulmonary atresia, pulmonary stenosis, PDA. Findings in cardiac cath: highly risky chance of rhythm disturbance, no characteristic feature. Now, what is the management of Ebstein anomaly? Medical management includes limited role: treatment of congestive heart failure during neonatal period, treatment of metabolic acidosis, prophylaxis of infective endocarditis, strenuous activity should be discouraged, measurement of arrhythmia with antiarrhythmic drugs, right catheter ablation. Palliative management of Ebstein anomaly: patients with poor RV function can be improved by unloading this RV by Glenn shunt, that is cavo-pulmonary shunt. In most severe cases, Fontan palliation, univentricular repair. Definitive surgery of Ebstein anomaly: repair of the valve or excision of the valve followed by valve replacement. Antibiotic treated semilunar allograft valve with atrial septal closure, Carpentier technique. In case of recurrent SVT, intraoperative right RF ablation or cryoablation, that is modified Mage procedure and division of accessory pathway located in posterior septal and RV free wall. For Viva, what is the indication of surgery for Ebstein anomaly? Presence of NYT3 and 4 symptoms: cyanosis or oxygen saturation less than 90%, tachyarrhythmias secondary to accessory pathway, presence of cardiomegaly, cardiothoracic ratio where more than 65%, presence of paradoxical embolism. Thank you.